Hello and welcome to this CME certified activity entitled Novel Approaches for Hormone Receptor Positive, HER2 Negative Advanced Breast Cancer, Making Informed Clinical Decisions for Your Patients. This is the first part of this activity and focuses on first-line therapy for ER-positive advanced breast cancer. I'm Dr. Harold Burstein, a medical oncologist at Dana-Farber Cancer Institute and Brigham and Women's Hospital, and an associate professor of medicine at Harvard Medical School. Thank you so much for joining us today. I have no real or apparent conflicts of interest to report. Please note the disclaimer from our CME sponsor, Axis, which you should be aware of. Our goal for today's activity is to discuss the optimal first-line treatment for ER-positive metastatic breast cancer, and we're going to do so in light of many of the more recent data that have been put forward in this space, and end our discussion by looking at a practical case application to help give people some ideas about where to go in the clinic. The learning objectives include evaluation of current guidelines for treatment choices for hormone receptor-positive breast cancer in the first and then second-line settings,
and
to interpret emerging clinical data on the efficacy of new treatment options for hormone receptor-positive advanced breast cancer. Before going into a detailed discussion of some of the pharmacologic options for patients who have ER-positive metastatic breast cancer, I think it's worth thinking a little bit about what we've learned in recent years about genomic tumor profiles and how that affects the way we think about breast cancer these days. Now, some of the most common mutations in ER-positive breast cancers include mutations in the PI3 kinase pathway and the MAP kinase pathway, mutations in the p53 oncogene, though those are somewhat less commonly seen than in the triple-negative cancers where they are nearly universal, and a variety of other markers that we're only beginning to learn to come to grips with. Now, how does estrogen receptor status affect response to endocrine therapy? This has been a topic of interest for decades now, and before we go into our latest update on this, I think it's really important to remember just how powerful endocrine therapy can be for ER-positive metastatic breast cancer. Back in the 1970s, there were multiple reports that looked at the use of anti-estrogens in women who had ER-positive metastatic disease. And I put this slide in here just to remind people that the response rates to these kinds of treatments were on the order of 70 to 75%. In fact, these were the original wonder drugs or targeted drugs. The same kind of excitement greeted these data as has greeted some more recent innovations with drugs like ibrutinib or crizotinib in different disease settings in oncology, where people are seeing really remarkable response rates. But oncology was led there by breast cancer, and we don't see these kind of responses quite so much anymore, not because the drugs don't work, but because the vast majority of our patients have already encountered prior endocrine therapy, which shifts the scale. But if you go to a population of de novo treatment for ER-positive metastatic breast cancer, you see really phenomenal success with anti-estrogens of all different kinds. We also learned from these early experiments in the 70s and 80s that the major predictor of benefit of endocrine therapy in ER-positive metastatic breast cancer was the level of expression of estrogen receptor and progesterone receptor. These are data from some canonical studies from Kent Osborne and colleagues that were published nearly 35 years ago. But they make the point that the stronger the level of ER expression on either the primary or the metastatic biopsy, the greater the likelihood of response. And in fact, tumors that are really ER positive scored as more than 100 femtomoles per milligram of tissue back in the old ligand binding assay days. This would be a strong, a 99% ER positive breast cancer in current practice. Response rates again on the order of, 60 to 80%. And similarly, tumors that were both ER positive and PR positive, far more likely to respond than tumors that were ER positive but PR negative, or of course for tumors that were ER negative. So we know a lot about what predicts the likelihood of response, and though the data aren't on this slide, this also affects the likely duration of response. So when you encounter a patient who has ER-positive metastatic breast cancer, things that can begin to give you a sense of the prognosis moving ahead will be the extent of prior therapy with antiestrogens and the degree of both ER and PR expression in the tumor, both at baseline or in the setting of metastatic disease. Now, of course, ultimately, endocrine therapy for metastatic disease does not cure advanced breast cancer, and patients do experience the clinical manifestation of progression despite endocrine therapy, and we refer to this as resistance. And for years, people have tried to understand the mechanism of resistance to endocrine therapies. At the first level analysis, the thing that does not happen is loss of estrogen receptor expression itself. In fact, most tumors that progress despite anti-estrogen treatment will still express estrogen receptor. But one of the interesting sets of data that have just come forward in the past year or two has been an analysis of constitutively acquired mutations in estrogen receptor that arise with endocrine resistance. So in these studies, investigators, including Renath Jesselson here at Dana-Farber and other work which has been done at other centers, took cancers and sequenced them both at the time of primary diagnosis, at the time of metastatic recurrence, and then at the time of progression. And what she found is that in roughly 15 to 20% of these cancers, there is an acquired mutation in estrogen receptor alpha in the ligand binding domain, which permanently turns on the estrogen receptor, such that it's no longer sensitive to manipulations either in the absence to withdraw estrogen or to use anti-estrogen drugs like tamoxifen. So these data are very provocative because they suggest that simply manipulating the hormone environment in tumors with these mutations is inadequate. You have to either degrade the estrogen receptor or you have to do something else to overcome resistance at this point. The other key point is that these are acquired issues. So here's an analysis that the same investigators did looking at mutational frequency of different mutations in either the primary or metastatic site. And what you can see is that for most mutations, these are part of the package of the cancer from the outset. They are present in the primary tumor and they are present in the metastatic site. And these include mutations in p53 and PI3 kinase and in cyclin D1 and so forth. But if you look at the hashed box, you'll see that the mutation in the estrogen receptor is something that was not present at the time of the primary diagnosis, but is now present at the time of tumor progression on estrogen therapy. So these are very provocative data and really are the first data to give us some sense of the dynamic changes that arise with resistance to endocrine therapy in the metastatic setting. This is another slide that just makes the same point about how they went about these assays. They took primary tumors, women who had recurred despite tamoxifen or aromatase inhibitor therapy. And in ongoing work, it looks like somewhere between 20 to 50% of the tumors that progress in that setting will have acquired this mutation in the estrogen receptor, which, as I said, is an activating mutation. So that doesn't account for all of endocrine resistance, but it certainly gives us a major clue, and increasingly, as we are doing sequencing on metastatic disease, we are looking for mutations like this to begin to direct therapy a little bit. Well, let's take a broader look at the goals of therapy for hormone receptor positive metastatic breast cancer. Obviously, from the patient's perspective, the goals are to prolong and extend survival as far as possible, to improve and maintain quality of life. And one of the issues in managing patients who have ER-positive metastatic disease is that these are often situations where a patient has non-measurable disease, either bone-dominant disease or effusions in the abdomen or the chest or small lymph nodes or cutaneous lesions, the kinds of things that don't immediately lend themselves to easy tracking radiologically or on clinical trials parameters, but are very much a part of the patient's experience in terms of symptoms and disease burden. From the clinical team's point of view, obviously you want to maximize quality and quantity of life, reduce the side effects so that they minimize interference with the patient's lifestyle. And really the true endpoint for endocrine therapy is how long can you go until you have to start chemotherapy. For most patients, that transition from endocrine therapy to chemotherapy is associated with a major change in the time commitment in the oncology clinic, the side effect profile of therapy. And so milking as much as one can out of anti-estrogen treatments is really part of the art of oncology. It's not uncommon in clinical practice to have situations where patients may even experience small degrees of tumor progression, but we don't react so dramatically. So for instance, we frequently see situations where patients who have ER-positive metastatic disease in the clinic, might have a lymph node in the mediastinum that gets a little bit bigger. It's probably progressing, but at the same time, the patient's totally unaware of it, And to pull the chemotherapy trigger for something like that seems inappropriate. So that's one of the interesting things about the goals of therapy in advanced breast cancer that's ER positive, which is that we are sometimes doing things that don't jibe precisely with how a clinical trial would structure treatment. It's harder to measure response in many of these women, and we often treat even when there is subtle evidence of progression as long as the patient is otherwise doing well. Now, one of the other things that's interesting about managing ER-positive advanced breast cancer is that the historical literature suggests that patients who experience stabilization of their disease do every bit as well as patients who have overt clinical response. So these are examples, again, drawn from papers in the 1990s when they were looking at an aromatase inhibitor such as anastrozole versus a progestational agent such as megestrol acetate. And the analysis here is of time to tumor progression, and it makes the point that women whose cancers either overtly responded or stabilized had the same longer-term outcomes in the way of survival as did patients who had response. Obviously, if there's no response whatsoever, then the outcomes are far less good. But for many patients with ER-positive disease, stabilization of disease is going to be a legitimate endpoint for clinical management. Well, let's speak to a few other distinctive clinical features of ER-positive metastatic breast cancer. One of the things we've learned as we've begun to appreciate more clearly the important subsets of breast cancer is that not all cancers metastasize to the same sites. And busy clinicians already know these kinds of information, but ER-positive cancers, luminal A or B cancers, are more likely to go to bone or lymph node as their initial sites of metastatic disease. Classically, they also can go to serosal surfaces such as the pleura or the peritoneum, especially lobular type breast cancers. And they're a little bit less likely to go to some of the visceral organs, such as the brain, liver, or lung, as their initial site of presentation, compared to women who have either HER2-positive breast cancer or triple-negative breast cancer. One of the other things we've learned is that there are differences in the modern era in terms of long-term survival based on the subtype of breast cancer. So these are data from our own institutional experience at Dana-Farber looking at overall survival from the time of metastatic breast cancer diagnosis in women who did receive chemotherapy for advanced breast cancer. What you can see is that the patients who do best these days are those who have either HER2-positive breast cancers, shown in blue, or ER-positive breast cancers, shown in red, with median survivals on the order of about 5 years. And by contrast, triple-negative breast cancers still have a far less good outcome, median survival more on the order of about 2 years, despite the use of chemotherapy. And once you start down the chemotherapy path for women who have ER-positive breast cancer, in our own recent experience, we are typically seeing that patients are receiving about 4 or 5 lines of therapy for metastatic disease. That's chemotherapy beyond whatever endocrine therapy they had already received. So the point there is that endocrine manipulations are part of the long spectrum of management for ER-positive disease, which will include nowadays hormonal therapies, chemotherapies, and the emerging estrogen receptor targeted therapies in the middle. Now, one of the common questions we are asked is, if a patient has first-line metastatic disease that's ER-positive, should they receive chemotherapy right away or endocrine therapy? And this question was actually studied quite heavily in the 1980s, looking at older endocrine therapy drugs like tamoxifen and older chemo regimens such as AC or CMF. And the key takeaway point was that there was no real advantage for initial therapy with chemotherapy compared to hormone therapy in these patients. In fact, in many studies, the overall survival was better in the women who began with endocrine therapy. So in general, whenever possible, it's optimal to start with endocrine treatment in the first-line setting of ER-positive disease. There are a few patients who really have pending visceral crisis, who have overwhelming cancer burdens, who need a response right away, if you will. And in those patients, we're all tempted to give some chemotherapy to sort of get the whole induction process going, with the hope that once the patient is better, we can transition away from chemo back to endocrine manipulations. Finally, before we get into more of the details of treatment, it's worth remembering that the landscape for therapy for ER-positive metastatic breast cancer has changed dramatically in the past few decades because of the widespread introduction of adjuvant endocrine treatments. So if you remember those papers we were talking about a few minutes ago where they're looking at 80% response rates to single-agent endocrine therapy in the metastatic setting in the 1980s, that's because none of these patients had received endocrine manipulations for early-stage disease. And then through the 1990s, as tamoxifen and then later on as aromatase inhibitors and tamoxifen became universal parts of the adjuvant experience, by the time a patient presents with metastatic disease, they've often had 5+ years of anti-estrogen therapy. So it's not surprising that the results look a little different, and it's not surprising that we clearly need newer agents now to manage those patients who do have recurrence despite tamoxifen and AI treatment. So let's look then at some of the more recent contemporary trials of management of ER-positive metastatic disease in the first-line setting. One question has been for a premenopausal woman, what do you do to optimally manage her disease? And these trials looked at the question of tamoxifen alone versus the combination of tamoxifen and GnRH agonist therapy versus single-agent GnRH agonist treatment. And what these studies showed was that the combination of tamoxifen and GnRH agonist treatment was clearly better in terms of overall survival than either one alone. So in a premenopausal woman who has ER-positive metastatic disease, the first thing you're going to do is shut down ovarian function, typically with GnRH agonist treatment, and add anti-estrogen therapy, either with tamoxifen or then an aromatase inhibitor right away to get them going. For those patients who have developed first-line disease after tamoxifen-based treatment, one of the questions has been whether it's better to give an AI or to give a selective estrogen receptor degrader such as fulvestrant. And this has been looked at carefully in several metastatic trials. In earlier work using a lower dose of the fulvestrant, anastrozole and fulvestrant showed exactly the same results in terms of time to progression at around 5 or 6 months for women who had previously received tamoxifen-based therapy. Similarly, for patients who had received AI-based therapy in the adjuvant or a little bit of the metastatic setting, there was a study that compared fulvestrant versus exemestane, the so-called EFFECT trial. And that study showed very similar response rates, clinical benefit rates, and time to progression for either of these two strategies. Now, one of the key points here is, again, that the fulvestrant dose was probably not optimal. In these earlier trials, they were using fulvestrant at 250 milligrams every month. And what we learned in the so-called CONFIRM trial was that a higher dose of fulvestrant is more effective. These are the data presented by Angela DeLeo from the CONFIRM study, just making the point that the 500 milligram dose was clearly superior in terms of progression-free survival than the 250 milligram dose, and aside from the need for a second injection, really was not associated with any more in the way of side effects. So that led to the question, well, if you use the higher dose, the 500 milligram dose of fulvestrant, how would your results compare against the AI based on the older literature? And here is a very interesting set of findings which suggests that if you do that higher dose of fulvestrant, you might even see results that are slightly better than AI therapy. These are data from John Robertson, who has presented the first trial, which looked at fulvestrant versus anastrozole in de novo metastatic disease and showed that fulvestrant might even be better with respect to time to progression. And so I think either of these really emerges as a very good option for first-line treatment. One of the other questions has been whether it's best to give combination therapy of an aromatase inhibitor and fulvestrant, or rather just single-agent therapy with an aromatase inhibitor. And here there's been a conflicting set of data. In the so-called FACT trial, led by Jonas Berg in the European Consortium, the use of anastrozole versus anastrozole plus fulvestrant led to the same outcomes in terms of progression-free survival. And by contrast, in a US-based study, SWOG 226, which compared anastrozole with or without fulvestrant, same doses of these drugs as the FACT trial, same exact schedule of administration. In this trial, actually, the addition of fulvestrant as first-line therapy with anastrozole improved progression-free survival and also improved median overall survival, which was a rather unusual thing. So how can you reconcile those two differences? And I think that the likely explanation is that the patient populations in the FACT and the SWOG trial were really very different. And in one respect, they were very different in terms of the women who'd previously had tamoxifen. So many of the women in the SWOG 226 trial had not previously had tamoxifen or were many years removed from diagnosis of early stage disease. And it was in those women, those who were 10 years out or had no prior tamoxifen therapy, that you really saw this signal that combination endocrine therapy, fulvestrant, and the AI was better than just the AI alone. And this, the highlighted red boxes make that point here on this slide. So there's one more trial in this vein. It was the so-called SOFIA trial. Again, fulvestrant versus the AI versus the combination of the two in women who had previously had AI therapy, a more refractory population. And in this setting, no real difference there. So let's look at all three of these trials. SOFIA, in fact, showing that combination therapy was not better. SWOG suggesting combination therapy was better. The key points I would draw your attention to: the SWOG trial, 40% of the women had de novo metastatic disease. Fewer of these women had previously received adjuvant endocrine therapy with tamoxifen. And in that group, they did better overall, and it looked like there was a signal that combination therapy might be helpful. So I have been influenced by these data. So if I see a patient who has had tumor recurrence or progression on adjuvant AI therapy or tamoxifen, and they've done so in a relatively short period of time, a few years since diagnosis, I typically just use single agent therapy for the anti-estrogen piece of this. But in a woman who is many years out from diagnosis or who is de novo presentation of metastatic disease, I'm more inclined to use combination therapy of fulvestrant and an AI, given the potential benefits in the SWOG 226 trial. Now, there are other older anti-estrogen options for treatment as well. These include estrogen therapy itself, and Matthew Ellis, previously at Washington University in St. Louis and now at Baylor College of Medicine in Houston, has really been a champion for this. And he revisited a treatment from the 1950s and 60s, looking at estradiol as therapy in the modern era. And even though this is a study that added estrogens to ER-positive breast cancer, which seems very counterintuitive, they actually showed that you could see clinical responses and clinical benefits in that patient population. So where does the literature stand moving forward? Well, we know that there are ongoing trials looking at fulvestrant versus AI therapy at higher doses to really define whether there's an optimal first-line regimen. These are trials such as the Falcon trial. And we also know that there are a lot of choices. So on this slide, you see the NCCN practice guidelines as they exist for management of ER-positive metastatic disease. Again, to make the point that premenopausal women should have ovarian suppression and then be treated as postmenopausal women. And for postmenopausal women, there are a variety of traditional choices, including AIs, fulvestrant, tamoxifen, estrogens, and in the next section, we're going to be talking about some of these newer targeted drugs, including palbociclib and everolimus. So key points to take away: endocrine therapy rather than chemotherapy is the preferred first-line regimen whenever possible. Secondly, tumor type is critical for thinking about prognosis, but at the moment we don't have better biomarkers to really guide therapy. So I think we've already covered several of these, but we will get into more detail of some of the discussion as we move forward into the discussion of the newer targeted drugs. But for endocrine naive patients, it's AIs or AIs with fulvestrant and consideration of AIs with drugs like palbociclib. And for patients who've already had therapy in the adjuvant setting, thinking about AIs with or without palbociclib or tamoxifen as first-line treatment, probably the simplest things to do. Well, in the last couple of minutes, let's switch to a case. Here we have a situation of first-line therapy for ER-positive breast cancer. This is a woman who's now 63 years old, and 12 years ago she had a mastectomy for a 2.5 centimeter grade 2 tumor that was node positive. The tumor was ER and PR positive and HER2 negative. She received chemotherapy with doxorubicin, cyclophosphamide, followed by paclitaxel, and had chemotherapy-induced amenorrhea. She then received post-mastectomy radiotherapy, several years of tamoxifen, and then 5 years of the aromatase inhibitor letrozole. She's now about 2 years out from her endocrine treatments. And she presents with nonspecific symptoms, including bone discomfort and fatigue. Laboratory tests suggest an elevated alkaline phosphatase and elevated serum tumor markers. A bone scan, shown on the next slide, showed suspicious lesions, and a bone biopsy confirmed ER positive, PR positive, HER2 negative cancer. Here's the bone scan, which I think is actually quite typical of what we see in breast cancer patients, involvement of the ribs, skull, or calvarium and vertebral bodies, very common. So how might you think about this patient? Well, I think you've got several good options. You could either do you could either do fulvestrant, that's our first choice, fulvestrant with palbociclib, letrozole with palbociclib, or everolimus plus exemestane. And just, I guess, to answer that question, up until quite recently, I probably would have offered a patient such as this fulvestrant therapy. She's already had tamoxifen, and she has also had an AI. And these tend to be the kind of patients who might have those acquired mutations in estrogen receptors, such that a degrader option is a good one. However, this patient also meets the criteria for reintroduction of an AI with palbociclib, the FDA approval for that drug. And based on the recent Paloma-3 data, which we're discussing in the next portion of our discussion, there's clearly a rationale for including palbociclib as well. I don't think that one can dogmatically say there's an absolute preferred treatment here, but in a patient who is mildly symptomatic, I am increasingly tempted to add palbociclib to the anti-estrogen regimen. Everolimus and exemestane is also a reasonable regimen for patients previously treated with an AI, though in my own experience, there's greater toxicity with that, and so I would probably choose one of the first options built around palbo. So with that, we're going to conclude the first portion of our discussion, and hopefully you'll join us shortly for the second portion. Thank you very much.